clavicle removed so you can actually see it. Again, what they've done is they splayed it out. So in life, when you look in the lab, look at the tiny little hole. All this has to pass through behind the clavicle, over the first rib, in front of the scapula, and all this stuff. It has to go through that hole. So in real life, it's about the size of a garden hose all squished together. There's an artery and vein right around it. So, but there is some nice images in the clinical anatomy, and the second half of the brachial section is really good for that one as well. So we've been where we're going. We're going to talk about a whole lot of ligaments and joints associated with the pectoral girdle, shoulder girdle. Talk about this rhythm between the scapula and the humerus and how you can get such mobility out of the arm. And then blitz, a whole bunch of muscles for the shoulder. Okay? So we talked about this last time, the brachial plexus. I'm not going to go over it all over again. It's just something you have to sit down and kind of memorize. And break it into roots. These guys, the trunks, the divisions, which are kind of easy to remember, they basically occur behind the clavicle. How they come together to form the cords, and then in green are these terminal branches. The terminal branches are the main nerves for the arm. The radial nerve supplies almost everything on the back of your arm, upper and lower arm. All the median nerves supply the forearm and muscles of the hand, and actually nerve supplies two muscles in the shoulder. And a musculocutaneous nerve here supplies the flexors, the front compartment of the upper. So basically that's your whole arm right there, these ones that come together. I always talk about the orientation. You can sort of see they sketched in light paint the first subclavian artery, then axillary artery, and then finally becomes the brachial artery in here. And it's the orientation of these guys, these cords. One's lateral, one's medial, and the posterior one is behind the axillary artery. And off a bunch of these parts come very important nerves, some quite high up, which you should remember because they go to some of the muscles we'll be talking about shortly. Okay. So again, here's another picture from Hollingshead. They talk about orienting the M of the brachial plexus around the artery. If we go back to the previous, oops, too far. Go back to this image here. In green, you can see the M. So basically, it's where the lateral and medial, what are called roots of the lateral and medial cords, come together to form the median nerve. So if you can find that, you can then trace the median nerve down. You find out where the root splits off, the other nerve will be ulnar, the other side will be musculocutaneous. Then behind it is the radial and axillary nerves. So it's a really good landmark when you're dissecting to find what's called the M. And sometimes it's a pretty atrocious M, meaning that the branches are unequal, they don't come off at the same spot. But it's usually there. Oh, I'm jumping around today. So, shoulder ligaments. So in this slide, it's a nice figure from Moore, version 6. In red are the ligaments of interest for the sternoclavicular joint. So one part where the clavicle joins the sternum, the manubrium. And in blue are the critical ligaments for the acromioclavicular, or the distal part, of articulation for the clavicle. We go through this joint first, the sternoclavicular joint. It is the only way your arm physically attaches by a joint to the thorax. Okay, it's the only point of contact. It's a direct strut. So it's a very complex joint. They talk about it as being a saddle joint because of its shape, but you'll see it kind of functions almost like a ball and socket joint. It's fairly sturdy. In fact, rarely does it ever dislocate. And if it's ever going to dislocate, it's going to come anteriorly. So the capsule around this joint is thickened on the front by the anterior joint, anterior sternoclavicular ligament, which is not that thick. Actually, it's just a thickening of the capsule. So this would be an intrinsic ligament, where the capsule gets thick on the front. And posteriorly, you can't see it, is a very thick part of the capsule called the posterior sternoclavicular. And they are basically thick things out of the capsule. So the posterior one is really thick, meaning it's almost impossible to dislocate the sternum backwards. Good, because lots of important stuff in here, right? Major aortic arch, trachea, esophagus, all in here. So you want to protect it. So they don't usually dislocate posterior. Running in between them is another ligament. So joining the two sides, sort of bridging them, and actually attaching right at the top of the manubrium, so what's called the sternal or jugular notch, is the interclavicular ligament. Kind of holds them together. The other thing that's hard to do is to pull the joint apart, to pull a retraction away from its attachment. You got this interclavicular one that tightens, and you got both the anterior and posterior sternoclavicular joints holding this thing in its groove. Interestingly enough, although it is a synovial joint, it likewise has a little disc. So each end of the clavicle and the sternum will be covered with hyaline cartilage, making it slick. And then there's a little wedged-in disc of fibrocartilage right in between it. Okay, so it helps like padding to help support the joint. Lastly, it's shown on this side clearly, it's also here but not highlighted, is this costoclavicular ligament. So it's going to run from the costal cartilage of the first rib up to the underside of the clavicle and help to anchor it down. It doesn't restrict all motion in an elevation way with rotation, but it prevents the clavicle from basically dislocating superiorly. It's pretty thick. And those are the main ligaments for the sternoclavicular joint. So what can that sucker do? Okay, it's the attachment that the whole shoulder has to rely on for mobility. As far as elevation of the scapula, depression of the scapula. So you can elevate and depress the scapula almost about 60 degrees of clavicular angle. So this thing can rotate up almost 60 degrees, like a hinge. And by doing that, you can actually depress and elevate the scapula. Cool. You can also move it forward and backwards. So you can retract your shoulder, or you can bring your shoulder forward. And in that action, what's happening is the clavicle is also hinging this way. Okay? So the strut's staying there, but it can go up and down, or forward and backwards. It goes forward about 30 degrees, goes forward and backwards about 30 degrees, 20 and 10 and then posterior. And that's because of this disc. But the last thing that really is kind of cool about this joint is when you go in the anatomical position into full abduction, as you get to, I don't know where it is, somewhere in this arc, you feel the part of the clavicle near the sternum. As you go up, what you'll feel is the clavicle rotates superiorly. So that front edge, the one that's convex, concave, rotates up about 90 degrees. And that's how you can get full abduction. So this is a very intriguing joint. That's why they talk about it as sort of a modified ball and socket. It can hinge this way, it can hinge this way, but as you're going up, it actually can rotate. And it can rotate again, because it's got this disc. Isn't that neat? So very, very mobile. And in fact, we'll talk about this, but in the anatomical position, if you raise your arm, you can get it only so far, okay? Because the greater tubercle starts to bump up against the underside of the acromion. So then when you can get it fully up, is you externally rotate the humerus, bring those tubercles out of the way, and now you can get your hand all the way up to the sky, 180 degrees, okay? So very, very mobile joint. And think of it, it's the strut that the whole shoulder is now articulating on. It's very impressive. The other end is the acromioclavicular or AC joint. Not so strong. So again, it has a thickening on the capsule, on the superior aspect. It's a little thicker. It's called the superior acromioclavicular ligament. It's on the top. There's a paper-thin inferior one. There's 3/4 of a disc in here. Okay? It's like a little wedge. It only dips in from the top. So it's an incomplete disc. I don't know why. Maybe if you go back in species before us, cats, who knows? There'll be some reason why it's slowly disappearing. So that, unfortunately, is not very solid as a joint. It's the weakest part. But it allows you to articulate the acromion of the scapula directly with the clavicle. Now, thank God, we have this area here, the corticoclavicular ligaments. These ones run from the coracoid process, that little nose piece in the scapula, up. And one part, the more medial part, is called the clonoid ligament. The other part is called the trapezoid ligament. You need to know both parts. They're really thick in life. They basically are going from the clonoid process up and grabbing the clavicle from underneath. So obviously they're going to prevent, or want to prevent, the clavicle from moving away from the scapula in a superior direction. But also, by tying itself into this way, being, I guess it's called a sling, if the clavicle is stabilized by muscle, then you're sort of hanging on to the scapula this way indirectly. So you have the direct acromioclavicular joint, and you have an indirect one, this one, coracoclavicular ligament, suspending it. So it's nice. It allows a bit of mobility, but not too much. So it means all this other movement of the scapula has to be occurring here, this acromioclavicular joint. That's where the motion occurs. So it's common to basically separate your shoulder, which would be to blow the AC joint out. One is just direct impact, you get boarded in hockey or you land on an outstretched arm. You can tear this ligament, but hopefully you don't tear those. And what you end up with is a little bump here, and it eventually will heal. You tear the acromioclavicular joint and you blow the ligaments out, then you have a true separated shoulder. Some of the rugby guys probably have this. And if you look at them as you go out on their shoulder, there's a step deformity, literally. You go along and then, okay, that's a step deformity. And it's basically this joint is gone, and these either can be repaired or they're gone as well. And then you have a fairly unstable AC joint. Okay, so these two joints, critical for this thing, being able to get around all over the place. It's nice to have this ball and socket joint, but it's the movement of the scapula that really adds to it. Okay. So, if you think about cutting through the joint, you can sort of see where this little disc would come in through 3/4 of the way through the gap between the two of them and the acromioclavicular joint. You can also see from above the articulation, there'll be facets here, and this thing would be welded together with ligament and then suspended from the coracoid process is the other part of the coracoclavicular ligament. But the neat thing is there's a rhythm, or the scapulohumeral rhythm. So there's a physiological joint involved here, and that's between the scapula and the back of the thorax. Okay. Both are covered with muscle. So it's not bone-on-bone interaction, it's not a true joint. But because of the architecture of the scapula, it can glide, right? We know it can elevate, can depress, can retract, can protract. And just think what protraction is. Protraction is actually not just going forward, but rotating in space. So you throw a punch. The scapula, keep it around your thorax. Last one is the angle can change. So the inferior angle can swing out, or the glenoid cavity can swing up. And that's what happens when you fully abduct the arm. So they talk about the first 15 degrees here from anatomical position and abduction of the shoulder. That's all glenohumeral. Nothing's happening anywhere else. But from there on, it's a 2-to-1 ratio. Okay. So for every 2 degrees that happen at the glenohumeral joint, 1 degree happens between the scapula and the thorax. And that's how you get full abduction. That's why this mobile scapula is important. Ball and socket is nice. The whole ball and socket is now moving on a mobile platform. And that's what makes the shoulder so special. Okay, so it's about a 1-to-2 ratio. 6 degrees will happen at the scapulothoracic, and 120 will happen usually at the glenohumeral. And they're king of redundancy, same thing. And you can actually check this out in the lab, because I guarantee you, 20% of you, depending on what athletics you do, or just you may be wonky, that's a polite word, will be asymmetric. And as you try to symmetrically abduct your arms, you'll notice one scapula will take off, it won't be moving yet, and then the other one will catch up. And then this one might race forward and slow down, the other one will catch up. Your arms are just moving perfectly, but the rhythm is off. And sometimes, depending if you're a sports pitcher, you have a really weird rhythm. That can cause a lot of problems in mechanics later on. So have a look in the lab. You can either watch someone's shoulders from behind, or you can actually palpate them. Just ask politely, put your hands on the scapula, have them abduct, see what happens. You should get 60 degrees of motion here, but they may move asymmetrically. and hopefully they both move. Okay. So, the critical joint now is the glenohumeral one. So the glenoid head of the humerus, and the head of the humerus, and the glenoid cavity, which is the hollow end of the scapula. So glenohumeral. Ball and socket, shoulder. The main joint. If someone says shoulder, that's what they're talking about. So we come down to this panel here, in the bottom. Critical ligaments to keep in mind. We've already talked about the acromioclavicular ligament up here, and coracoacromial ligaments. Oh, sorry, coracoclavicular ligaments here, conoid and trapezoid. You can actually see them better there, how they rise up from the coracoid process. One that we haven't talked about is coracoacromial. And for the life of me, I don't know why they call it a ligament. Think about what it's running from. It's running from the coracoid process of part of the scapula to the acromion, another part of the scapula. It's the same freaking bone. And yet it's going right across there. So dense connective tissue, because it's going to bone, you could say, sure, it's a ligament. But in fact, what it forms is sort of the roof of this area over top of the humerus. And between it, coracoid process, the acromion, you've got a nice roof on top of the shoulder joint. So it's really almost, in fact, it is impossible to dislocate it superiorly in an anatomical position. You can't. What instead will happen is you either blow out ligaments or you'll fracture the surgical neck of the humerus. It will be a first or the clavicle might blow. But you'll never go through this area here. It's thick. So thick ligament forming the roof. If you come to the front, so lesser tubercle, greater tubercle, there's a groove in there. Bicipital groove is how I learned it. Intertubercular groove is how it's called now. It actually is a channel that allows the long head of biceps to course through it. And in real life, there's a ligament that goes right over top of it called the transverse humeral ligament that turns this groove into a tunnel. So the long head of biceps is actually buried in the joint. We'll talk about that on Wednesday, and it exits the joint through this groove and through this tunnel. There's a mistake in the slides, unfortunately. Coracohumeral ligament, he's got it running this way, from the base of the coracoid process to the lesser tubercle. It doesn't. It goes all the way across to the greater tubercle. If you read it in the book, you see he writes it right. He just shows it wrong. Okay, so other images, I'll try and have one for the next class. The ligament actually spans all the way over to here. And it sort of forms part of the front of the joint. Now in the actual joint capsule itself, the capsule's pretty loose. Has to be, right? Think about everything you're doing with this joint. Pretty amazing. So the only time the capsule really gets tight is on full abduction with a bit of extension. That's where the joint capsule gets really tight. Anywhere else, especially the anatomical position, the bottom of the capsule is really loose. So this is actually a point of jeopardy for the joint. If someone was to hammer me on the top of my shoulder, or to pull down on my humerus, I can dislocate that way, no problem. Okay. Going upwards, too much in the way. Downwards, not a lot in the way. Okay. And so it's these ligaments that you'll see when they do a cross section through the joint, sagittal section, pull the humerus out of the way. What you see is on the front aspect of the capsule, it's thickened in 3 bands, 1, 2, and 3. These are the glenohumeral ligaments. Superior, middle, and inferior, which are basically bands that thicken the front of the capsule. This is good, because again, dislocating anteriorly, purely anteriorly, is hard because of that and all the other muscles around it. So the joint's fairly solid, except down, and unfortunately down and anteriorly, especially if your arm's over your head. So if you fall or something hits your arm, you pull someone's arm here, there's not a lot preventing it from dislocating in an inferior, anterior direction. It's the most common dislocation, and the head kind of pops over here, and someone's walking around the head with their arm. Daniel, I can't remember his last name, football team. Okay. Tackle. I can't remember how he said it. Tackle this way and that way, and went this way. Okay. So these ligaments help to fortify the anterior part of the capsule. There's a labrum, or a rim, if you wish, around the glenoid cavity glenoid cavity has been covered with hyaline. So right around the outside of that, it's a tiny layer of fibrocartilage, called the labrum. If you think about it, glenoid cavity is not very deep, right? It's a little cup, and the humerus has to sit on that. So what this labrum does is it gives a little more depth to it. So they say it's about 1/3 of the head of the humerus can actually fit into this little cup. If you think about it, the way the cup's oriented, it's almost vertical, meaning what's preventing the humerus from falling out, right? Well, ligaments and muscle. For one thing, it's a lot of muscles. So these are the glenohumeral ligaments. And in cross section, what they've done here is instead of doing a sagittal cut like that one, they've gone right through it in a coronal cut. Bang. And then you're looking in from an anterior view. You can see the head. There would be hyaline cartilage on both the glenoid and head of the humerus. Here's the capsule. Again, remember it's a synovial capsule. There's the acromioclavicular joint on top, and what they're showing you is the long head of biceps, the way it curls into the inside of the capsule. It actually attaches to the top of the glenoid labrum, right on top of the glenoid. There's a notch, supraglenoid tubercle. That's where the long head of biceps actually takes its origin, or one of its attachments. So it goes through the capsule. It's a really nice image. Okay, muscles. You ready? You've been waiting for this. Now draw the joints and ball joints. This is what I want to do. Good. So you're gonna get it. So deltoid, everybody probably knows what deltoid is. In red is its nerve supply. Remember the brachial plexus? That's a terminal branch. Excellent. Okay. So the deltoid takes its purchase, one end of its purchase, if you wish, or its proximal attachment according to Moore, from the outside distal parts of the lateral parts of the clavicle, sometimes called the clavicular or anterior component. Also take it from the spine, laterally, on the scapula. That's the posterior part. And then right around the acromion itself. That would be the middle part. Okay, so either anterior, middle, and posterior, or clavicular, acromial, and spine. The three parts. Where does it insert? Remember, the humerus on the lateral side, there's a really big prominent bump halfway down on the outside of the humerus. Deltoid tuberosity. What's the difference between a tubercle and a tuberosity? Well, the tuberosity is bigger and rougher. So if you look at a real bone, instead of being this smooth bump, pocketed, it's going to have all these kind of holes in it because deltoid has a massive attachment down here. Okay, you've got it coming from the front, the middle, the back of your shoulder, all coming together, multipennate muscle, and attaching down here. It's easy to find. What's its function? Abduction. It's simple too. The anterior fibers, well, they can help flexion. Posterior fibers, well, they can help extension. All three together, they will abduct. Because the anterior and posterior kind of working as guy wires to help the middle part, the juicy part, abduct the shoulder. Okay? Nerve supply was excellent. Pec major, big muscle. Two heads. There's a sternal head, all the way along the sternum, down onto the costal margin. Some people refer to a third head, the abdominal component, which actually takes its origin from the external obliques fascia. So the lower parts of the sternal head are sometimes called abdominal. I don't even know what the word says. And then there's the clavicular head. So the medial component of the clavicle. So just where sternocleidomastoid inserts, that's the clavicular head. Fan-shaped muscle, all convene, come to a common tendon, inserts on the lateral lip of that intertubercular groove. The biceps tendon runs through. Okay? What does it do? Well, if your arm is abducted, it's going to very strongly adduct it. If your arm is externally rotated, it's going to want to be what? Internally rotated. Cool. Clavicular head, it's running like that. What can it do? From an extended position, the boulder's position, it's going to help flex to a neutral position. You reach up from the top of the shelf, get a can of beans, I don't know why beans, something else. Okay, the sternal head will extend. Here's a muscle you have to really think about taking out of the anatomical position. What can it do here? It can adduct and internally rotate the shoulder, that's it. But these other factions will play into it if you move out of that. Especially if you think your arm's here, what's it going to want to do? It's going to love this. Right? It's going to love adducting and internally rotating when you do cables. Right? Nerve supply. Lateral and medial pectoral nerves. They're on the brachial plexus. Where they come off. Lateral one comes off the lateral cord, medial one comes off the medial one. Lats, latissimus dorsi. Okay, big muscle, basically spines of the upper thoracic vertebra, and a massive fascia that goes across the back of your low back, on top of those deep muscles we've already talked about, called the thoracodorsal fascia, and the crests of your hip bones. So on each side, this is a pretty significant starting point. It's going to come up, you can't really see it here, it's going to come up. In between the thorax and the humerus, and insert on the anterior surface, right next to the pec major. Wow, that's a tough one. So what does it want to do? It'll help adduct from an abducted position. It'll certainly want to extend from a flexed position. If your arm is way up, it's going to want to do both, right? It's going to want to extend and adduct. And because it's on the front, it's a weak internal rotator. Likes to swim. Likes that motion. Its nerve supply also comes off quite high up on the brachial plexus. The latissimus dorsi is supplied by the thoracodorsal nerve. Just have to remember that. Okay, last one shown on this page, we're going to go over a couple of other images of these guys. The serratus anterior. Its nerve supply is the long thoracic nerve. Remember, that's one of the first ones to blow off the brachial plexus, right at the top. The top three roots come together and form the long thoracic nerve that then runs down basically inside of your armpit and your side to supply this muscle. And I'll show you in another image a little clearer. But it's serratus, meaning it's sawtooth. Looks like a saw. That's what they think anyways. So, remove those. Now we can get to pec minor. The pec minor is a tiny muscle. It's deep to pectoralis major. It has three basically heads that converge. So 3, 4, and 5 ribs and costal margins when they come together. That's where the small, I think it's distal attachment, or more. And they all converge and insert up into the corcoid process of the scapula. Interesting. Not very big, but its nerve supply is medial and lateral pectoral nerves. The reason I say that is in the tables, he'll say pec minor is only the medial pectoral nerve, and then when he's talking about the brachial plexus, he contradicts himself. Says it's both. You read anybody else in anatomy, they will say pec minor is both, as is pec major. So all you have to know, minor and major, both get innervated by the lateral and medial pectoral nerves together. So what would this do? Well, if the scapula is braced and isn't going anywhere, it'll pull up on the ribs. If the scapula is able to move, then pec minor is going to want to pull the corcoid process forward and around. So it's going to help with protraction. It's also going to cause a bit of depression. It's going to pull the scapula down. And it's going to pull the glenoid cavity down inferiorly. So I always talk about pec minor being involved in rotating the scapula such that the glenoid cavity tilts downwards. Again, better image of serratus here. You can now see its sawtooth origin. The next slide's even better. Usually the ribs either 1 to 8 or 2 to 9, depending on who you read. And I don't know what more says, probably 1 to 8. There'll be 8 of these little slips coming off the lateral border of the ribs, all coming together. And on the next slide, this is where they go. So here are all your distal attachments. They actually course underneath the scapula. So they're going to run around and pass between the scapula and the thorax, and they insert in this blue line here. So this is the anterior surface of the scapula. It's going to curl all the way around. They reflected the scapula there, showing you the muscle that's on top of that, here in red. Curling all the way around to attach on the medial border, but on the anterior surface. This is a funky muscle. It's going to come from here and all these many branches of it coming around, and it's going to curl all the way around between the scapula and the thorax to insert on the anterior surface of the medial border. So this is your punching muscle. This is the one that's going to contract. It's going to really want to pull the scapula around. It's going to help you get full reach if you're trying to grab something. Heavily involved in protraction. Okay. You can have paralysis of this. Common if you use crutches. This is the favorite PT clinical story. You know, you hurt your knees, you're on crutches all the time, and you're rubbing the sides of you can get contusion paralysis of the long thoracic nerve, which is right there as it's going into the serratus anterior, and you end up with a weakness of the scapula. Have someone just gently push against the wall, the scapula should stay right where they are. If serratus is not trying to pull it flat against the chest, you get what's called winging, and the scapula will pop out. You can do that. Some can do this. They can wing their scapulas voluntarily. But if you have people push against the wall and one side pops, it means they have a weakness in serratus on that side. Okay? Because that's supposed to be preventing this. So in the lab, lots of reds and lots of blues. You don't have to know them, right? That's origin in red, insertion in blue. Just two attachments. But sometimes it'll help you to remember where things go. So here's pec minor's attachments. It's three attachments from here, here, and here. It's going to go up and it's going to insert at that blue part on the medial side of the coracoid process. So you just need to know, okay, that's one attachment, that's the other. Makes sense. Here's the attachment to the sternal head, and to a lesser extent the abdominal head, and the clavicular head of pec major. And where is it going to insert? This big blue line right here. So that is where all this muscle is going to, this fan out muscle is going to come together, and it's going to insert just on the side of the other side of the bicipital groove. It's a bit long, actually. It's not that long. So you can see how if the arm is abducted, it's going to adduct. And there's one of the attachments for serratus as well. So this is probably not a bad idea. The one muscle I've kind of blown over was subclavius. I think it's a couple of slides back. Tiny, tiny muscle runs from here up to the other side of the clavicle. It's about the size of an earthworm on a cadaver. It probably helps to restrict dramatic superior elevation of the clavicle. It's probably also just juicy enough to help protect the stuff that's behind it, the subclavian artery. Okay. It's actually very hard to tease out of a cadaver. I don't do well with this one. I always destroy it. I'm trying to pull it. Okay, so having fun? Lots to remember, I know. Trapezius, most of you are probably colloquially familiar with this one, has three heads in blue on this side. There's a descending part, or what I call the superior part, that's how I learned it. There's a middle part, which I learned is the middle part, and there's an ascending part, which goes up. And all three are trapezius. And all three are supplied by the 11th cranial nerve, just like sternocleidomastoid. But if you look at it, it's all the way from external occipital protuberance and basically the medial third of the superior nodular line, the nuchal ligament, and all the spines, all the way down to T12. That's where these fibers are coming from. And then you break it into regions. Okay, if they're the lower fibers, they ascend up and they insert onto the spine and the scapula. The middle fibers kind of go more laterally, and they insert in the spine and the acromion. And then the descending fibers, acromion, forms part of the clavicle. And in the lab, look at that triangle that occurs right here. Okay? You have acromion, spine, clavicle. It's a triangle. So traps comes down on top of that. Deltoid takes origin and goes from there. If you were a cat or a dog, you would have a clavipectoral muscle, which is a continuation of the two of them. Okay? So they historically used to be one big honking muscle. But now you have traps and its attachments to the scapula, meaning that this muscle is only going to be able to move the scapula and the clavicle. It has nothing to do with the glenohumeral joint. And all three parts can think, well, what's the superior part going to do? It's going to help elevate? Sure. Inferior part is going to help depress. Medial part is going to help retract. And a hard one to get, Now you know why I use PowerPoint. Much. That's your scapula. You're looking at the left scapula. Okay? You can think of the superior part trying to do this, the inferior part trying to do that. But depending on where the center of rotation is, they can cause it to go up. And I'll point this out in the lab. So if the superior fibers are grabbing, they're actually grabbing out here. They're going to pull this way, inferior fibers are going to pull this way. This is called a turning couple. A lot of anatomy does this kind of thing. We have two different things pull in different directions, but they cause rotation. It depends on where the scapula is and the time is not. You just have to remember that superior activation and inferior activation will cause the glenoid cavity to come up. Is that important? Full induction. So they work together to rotate the scapula. There's a good picture of lats. It's horrendous origin, if you wish, or proximal attachment. This big fascia on the back is called the thoracolumbar fascia, thoracodorsal fascia. All the lower parts of the thoracic vertebra, their spines, and then it curls around under the armpit to attach in the front. So what this distorts again is the thoracodorsal nerve. Three little muscles that are quite deep once you move trapezius, and all have action on the scapula again itself. The top one is levator scapulae. Basically, the posterior tubercles of C1 to C4 all come together and inserts on the top of the scapula. We'll see in a bit. Rhomboid minor, tiny, tiny muscle, just from I guess it's probably C7, T1 spine, down to the angle where the spine joins the medial board of the scapula. And major, which is a little bigger. Rhomboid major, rhomboid square, or rhomboid shape. That's why they call that. But if you look at all three of them, levator is going to want to elevate the scapula. The rhomboids, they're going to want to retract it. And because of their pull, they can now take the glenoid cavity and dip it down a bit. So always think, if I'm going to shorten the points between the two attachments during a contraction, what's the outcome? You can see if you contract these guys, yeah, they're going to pull it in, but there's a center rotation somewhere here. As they pull in, they're going to pull the angle up a bit, and they're going to dip the shoulder down. Okay. Oh, nerve supply. So these primarily dorsal scapula. Levator scapulae, this one sometimes has some contributions from the upper cervical dorsal ring line, because it's like another back muscle. Last ones, and you've covered the shoulder. These ones now are interacting between the scapula and the humerus. Okay? And subscapularis, all from the subscapular fossa. This is now an anterior view of the scapula. Comes over and inserts on the medial edge of this groove where biceps long tendon comes in. Okay? So this guy is going to run from the scapula to the front part of the humerus. So you can see it's going to want to adduct. So here's going to adduct because it's on the front of the humerus. Big internal rotator on the humerus. So it's going to help the glenohumeral joint internal rotate. Okay. And subscapularis are the upper and lower subscapular nerves off the brachial plexus. It's quite, in life, it's quite a good sized muscle. It's like serratus, it's not tiny. Supraspinatus sits in the supraspinatus fossa, runs underneath the acromion to insert right on the top of the greater tubercle. So this one, it's almost dead center. So it's not really able to do any kind of internal or external rotation of the humerus in the glenohumeral joint, but it's perfectly positioned for that first 15 degrees of abduction. So talk about supraspinatus getting you going until deltoid can now further abduct you. If you have paralysis of supraspinatus and you try to abduct with deltoid, you just pull your arm out, right? So people cheat, and they'll do this, get that 15 degrees of purchase for deltoid to go up. Okay? So by doing this, you're actually getting that 15 degrees pull out, so now when deltoid contracts, it can fully abduct. So the two work together, and supraspinatus probably works to about here in helping with abduction of the arm, but it's really on deltoid to do the work. And commonly, because it's close proximity to the joint and underneath the acromion, this is where you end up with all kinds of what are called rotator cuff problems starting. I'll come back to that in a second. So, from posterior view, there's your supraspinatus, we just talked about them. Under the spine, medial border, under the spine would be infraspinatus, into the infraspinatus fossa. It runs, but now it's inserting on the greater tubercle, but on a posterior side. So it's behind it. And if you think about it, it can kind of abduct, but what it's really wanting to do is externally rotate the glenohumeral joint. Okay. So this is one of your external rotators of that joint. Below it, teres minor comes from the lower part of the lateral border of the scapula and inserts just below infraspinatus. But right on the head again, greater tubercle. So in the lab, what you'll see is three blue marks, one at the top, one in the middle, and one quite behind. Those would be supraspinatus, infraspinatus, and teres minor. Okay. And again, because the posterior, minor, it's going to want to do what? It's going to primarily want to do an external rotation. So if you were to compare, I'll come back to that. If you want to have someone externally rotate against something, think cable, or a rubber band against the door. When you're doing this, you're preferentially working infraspinatus and teres minor. Okay? They're the ones who really want to do external rotation of the glenohumeral joint. Let's see. So teres minor is auxiliary nerve. So if you remember, deltoid and teres minor are supplied by the same nerve. And you know the nerves, the only two muscles that are supplied by the axillary nerve. Infraspinatus is the suprascapular nerve. Supraspinatus is the suprascapular nerve. Comes off the brachial plexus and where? You should know that. Last one that's been cut, I'll show you another image, is teres major. So there's a minor, there's also a major, and it's a lot bigger, comes off the lower aspect, lateral border, right down near the angle, inferior angle of the scapula. It's going to curl around to the front, just like lats. So latissimus goes from the trunk, under the arm, and inserts on the humerus. It has nothing directly to do with the scapula. Nothing. Right? You can do all these things, but it's indirectly going to have an effect on moving the scapula because it's grabbing muscles that are glenohumeral in nature. Teres major, on the other hand, ties the scapula to the humerus, just like these other guys. So infraspinatus, supraspinatus, teres minor, and subscapularis are called your rotator cuff muscles because they basically insert right around the head of the humerus. And they are dynamic ligaments. Again, the humerus, poor thing that it is, sits like that. And what these muscles do is they grab it and hold it. And so with that comes a lot of motion of the glenohumeral joint. You've got to think that these poor muscles can get worn down quite a lot. So it's quite easy to get rotator cuff injuries. These are images from Moore, 6, again showing you subclavius. Nice landmarks like where the cephalic vein would be. You can see that in the gym on somebody. And they talk about all the same muscles we just talked about, some just better images. And again, this is another newer version of the same images I've shown you before, but I think it's handy at times not to shy away from what's blue and what's red, but to get in your mind, okay, this is where pec major will go, this is where pec minor will go. Because if you know where they go, then shorten the two distances and you know what the muscle can do when it's allowed to shorten. Again, reiterating what we did before, but look at it because the images are the newer one. And again, showing you these different attachment points out here. I will never ask you to dissociate between these on the front of the humerus. Where is glats? Where is? I might put a big blob of plasticine there and say, name the 4 muscles that attach there. That's fair. But I won't ask you which is which. Okay, they're just too close and too confusing, even for someone like me. Okay. And the last image is showing you just deltoid. These are all the same images, just done a little better than the previous Moore version. Okay, so you just had a whirlwind trip to the muscles attaching from trunk to scapula, trunk to humerus, scapula to humerus. And if you read more, that's how he breaks them down for you. It's very, very functional. What can I do? Can I act on the humerus but not the scapula? Can I act on the scapula? I'm on the scapula, I can act on the humerus. Think of it that way, and then you'll be able to handle them. You should know attachments. I don't care if they're origin, insertion, distal, proximal. Just know where they attach. Their nerve supply, their function. Okay? We will do upper arm on Wednesday. Thank you very much.